3/4 rather than 1/3, and overall episodes by about 80%, 80 to 90%. So, and the hospital rates continue to stay low or to be decreased by about a half. And those individuals who started in the study have continued to have those same low levels of episodes. My longest treated patient is triheptanone, which of course is Dojolvi. Is now 36. She's been on it for 34 years. And she's a VLCAD patient. So we have a number of folks who've been on this preparation for between 20 and 30 years now. So long term, we think it's very safe. And my bottom line is, if anybody asks me, I say that triheptanone should be used before you get sick, not wait until you get sick. Because why risk your life waiting for what we know is going to happen? And so I've been talking to lots of insurance companies, lots of other physicians, lots of national health networks in other countries advocating this as the indication for using Dojolvi. So now let's look at what's coming down the pike. And if Dojolvi is doing well, it's not fixing everybody all the time, and so that leads to the question as to why. We always assumed, and in particular, the muscle disease has been problematic. Our assumption before Dojolvi was around was that all of the muscle problems were related to energy deficiency. You burned out all your muscle's energy, it started breaking down as a result of that, and that was what rhabdo was. Well, Dojolvi tells us that that's partly true, but the rest of it may not be. So I view myself as being somebody with some common sense, and I try to be simple when I can. And so one of the things that I thought when we first started realizing that we were not fixing all of the rhabdo was, well, what else causes rhabdo in individuals? And one of the most common non-metabolic causes of rhabdomyolysis is inflammatory muscle disease. So I said, well, what if our patients are actually having inflammatory disease? And we did some early studies, and we couldn't find it in the usual markers. But then we started looking at a specialized set of markers called cytokines. And one of the advantages to having had so many of you come through my clinic for your clinical trials is that I've got bits of you in my freezer. I got your blood, I got your cells sometimes. So I just went into the freezer and I pulled out 8 samples from patients who had only had MCT oil, and 8 patients who had triheptanone. And sure enough, we found all of these inflammatory markers were elevated, whether you were on one or the other. So here, this is the first indication that inflammation is playing a role in this disease, and it moved us into the laboratory to look at things that might help us control the inflammation. First, we wanted to prove it. So, as I said, one of the things that we started with was looking at cell lines from patients with fatty acid oxidation disorders, and so here is a graph showing the reactive oxygens on the left of a control cell line, somebody who was otherwise well and was just a donor. And on the right, the levels of reactive oxygen in a patient with VLCAD deficiency. It's not too hard to see that the patients were very, very much higher than our control. We looked at one of the things that causes increased reactive oxygen in cells is respiratory chain defect. That other second cycle that we talked about, a second pathway that we talked about, and we do a specialized test where we look at the ability of the cells to burn oxygen. That's how you get your fuel. It's in the end, the fuel that goes to the respiratory chain is used to burn molecular oxygen and turn it into ATP. That's the cellular energy that's necessary for life. And if it's done inefficiently, what happens is it's the equivalent of burning lighting a match. You burn oxygen, and if you do it immediately, very very quickly, you get fire. Well, we can't have that in our cells, I guess, unless you're a comic book hero. If you control that burn, and at each step get some of that energy off, you can use it to make ATP. And if you do that just right, at just the right speed, you get ATP, but those intermediate steps between oxygen and fire are called reactive oxygen. And if it happens too slowly, that reactive oxygen sneaks out into the mitochondria. So we saw that the reactive oxygen was high a VLCAD patient. Here we can see that the function of the respiratory chain, the ability of the cell to burn oxygen, is decreased. So there's secondary damage going on here. Here the black bars are where a normal cell is, and the gray bar is the VLCAD deficient cell line, and it's just lower. So it means you can't. Not only are you not getting the fuel through fatty acid oxidation, but what you do manage to get into the respiratory chain isn't being used efficiently. We have, fortunately, at the University of Pittsburgh, a really terrific chemist, a medicinal chemist, who has spent much of his life looking at antioxidants that get targeted to the mitochondria. And he was developing them for a completely different reason. And I met him at a meeting once, and I said, did you ever think of using your compounds to treat these diseases? And he looked at me like, what are those diseases? I never heard of them. So I said, look, send me some of your stuff and we'll test it. And you can see here that the first two bars are control cell lines. Normal reactive oxygen isn't affected very much by using one of these antioxidants. That VLCAD cell line that had the real high numbers, you can see it's cut by at least half by treating with this antioxidant. It increases the VLCAD protein. On the right side of this, you can see that the green stain, which is VLCAD protein in this cell line, is less than the green stain in the cell on the left, which is the normal cell line. If we treat with one of these antioxidants, you go to the bottom set of panels, and you can see the green on the right side is increasing. And that's an indication that the protein is increasing. It also, excuse me, we've also found that common LCHAD mutation generates a lot of reactive oxygen, and only some MTP or TFP deficient cell lines generate reactive oxygen. I think I might have, on the left you can see that the LCHAD cell line responds very well to this antioxidant. And that one TFP or MTP cell line that was high also dropped by a little bit. So we're now actively looking for a company that's willing to help us develop this. Unfortunately, once you get past this stage, you're now talking tens of millions of dollars to get to FDA approval, and I don't have that kind of pocket change hanging around. So we were really fortunate to have Ultragenics as a partner to develop Triheptano, and we're looking for somebody to do the same thing with this drug. Now, triheptanone has been a real improvement in the lives of our patients. But one of the other possibilities for it not working as well as it might is it turns out it's almost used too efficiently by in this case MCAD is the enzyme that breaks down C7 to give those C2 and C3 molecules. And it does it so quickly that it almost is completely metabolized in the liver, which is where the food that you ingest as it's broken down, taken up in the intestine, taken up by the bloodstream. It goes to the liver first, and it's almost too efficiently metabolized in the liver, and we don't get a whole lot out into the muscle and the heart. So we've been looking at other similar kinds of fats with slight modifications that we think will be stymied a little bit in the liver and allow some of it to get out into the periphery. And the first thing to do is to just show that when we treat cells with these compounds, that they're at least as good as C7 in making propionate, the C3 molecule, and succinate, the TCA cycle intermediate that propionate makes. And so here what you can see are a variety of compounds that we've tried. The yellow bar is triheptanone in this experiment, and we can see that all of the other agents that we have are at least as good as at making succinate and close, though not completely equal to making propionate. And then we have also cell lines here. We have a couple of VLCAD cell lines. It works in LCHAD cell lines, TFP cell lines. Not as good in CPT2 cell lines. So we're not sure whether this is going to be they're going to work for everybody. But this is another set of potential agents that could be effective, and we're working with a company now to develop these and hopefully get them into clinical trials. Another avenue that we're working on is specific to LCHAD deficiency or TFP deficiency. It turns out that the trifunctional protein actually has 4 functions. Only recently recognized that in addition to its role in fatty acid oxidation, the LCHAD subunit of the trifunctional protein participates in making a very, very special fat in the body called cardiolipin. Why is cardiolipin so special? Well, it is a fat that mitochondria use to sort of fold into the shapes that it needs to be active, to have maximum effectiveness, and to be stable. And minus cardiolipin, the mitochondria have a tendency to start falling apart. And so another crossover with our respiratory chain friends, a company called Stealth Pharmaceutical has been developing a drug called Phenylbutyrate, and that drug it binds to partially metabolized or synthesized forms of cardiolipin and sort of helps them work better. And so since we know that LCHAD cells don't have normal cardiolipin, work that's being done in my lab currently, we treated cells from an LCHAD patient with a cardiolipin binding peptide, and we measured that reactive oxygen that we were seeing before. And what you can see here is on the left, the first 2 columns, normal and LCHAD cell lines, and then without treatment, and then on the right-hand side, with treatment. it normalizes it. So we've been looking for, I've been trying to convince Stealth to do a clinical trial with LCHAT deficiency for years and years, and I've almost had them convinced twice, and then, you know, pharmaceutical companies have a tendency to change personnel fairly quickly, and so the folks I was working with moved, and I had to start all over again. So I'm in my third round right now and trying to convince them that this is a good thing to do for their next disease to treat. It not only works in cells, but it works in a trifunctional protein deficient mouse. One of the ways that we measure energy metabolism in a mouse is we put it in the refrigerator. Now, if you take a catch a mouse in your basement and you put it in the refrigerator, it sounds like the title for a kid's book. Maybe I'll write that one. I'll have to get Stephanie to do my illustrations for me. The next fatty acid oxidation kids book. Anyway, that mouse is perfectly happy. It'll run around looking for a cookie or cheese or whatever you happen to have in the refrigerator. However, if you take a fatty acid oxidation deficient mouse, you put it in the refrigerator, it starts getting cold, and if you leave it in there long enough, it dies. And what you're seeing on the left is a chart that shows that. And that very low line there, the red one, you can see that an untreated TFP deficient mouse is at about 3.5 hours has dropped its temperature to a level that we stop the experiment, because we know that mouse is going to die. We don't let it die. We pull it out. If we treat with the cardiolipin binding peptide, it keeps the mouse at a temperature that is still lower than normal, but high enough that it survives the 4 hours of this test. And so it looks like it's working at a whole animal level. So once again, we're working on trying to get this into clinical trials for patients with TFP and LCHAT deficiency. I'm going to shift gears a little bit. These experiments were all ways of trying to work on the metabolites, the chemical balance in the cells in the body caused by fatty acid oxidation deficiency. Well, what if we forget about that and we actually try to replace the enzyme that you're missing? So we have two ways of doing that right now. One is using something called messenger RNA, therapeutic messenger RNA. And this is a molecule that contains the information that the cell needs to make the protein. And you can give that by an IV infusion. It gets into the cells make the enzyme, and it gets to where it's supposed to be. And we can tell that by a number of ways. And I'm just going to point you to the top left panel of this slide. And this shows a technique that allows us to see the proteins that we're working on. So you can see here, VLCAD is the dark band at the top of the leftmost lane, and another protein that's not affected by VLCAD deficiency is at the bottom. If we measure VLCAD in a VLCAD deficient mouse liver, you see the second line there, where the second slot over, and you can see the VLCAD band is missing. If we then give that mouse the VLCAD therapeutic mRNA, now you can see the band is back, and it looks just the same as the control animal. And so it'll hang around long enough that if we were to do this in people, you'd probably need to repeat this therapy once every 2 to 3 weeks. So it's much like the enzyme replacement therapy that we do for a lot of our diseases, except we can't give mitochondrial proteins per se, so we have to do it this way. Unfortunately, this drug was being made for us by a then little-known company called Moderna. And one of the other things that they were working on at the time were vaccines for little-known African viruses. And then March 2020 came, and there's suddenly a new virus on the scene. Moderna got a little distracted from their fatty acid oxidation work, and now a couple of years later, they're just not going to be developing this any further. So we're working on, once again, finding a partner in the pharmaceutical world. Moderna is being gracious enough that they're going to let us move this forward if we can find somebody that's willing to pick it up and do the development. And the nice thing about this is that the amount of work that we have is probably enough for the FDA to let us go straight to a clinical trial. So hopefully, once we find that partner, and we've got a couple of companies that are talking to us about it now, we'll be able to move this into clinical trials pretty quickly. I think I'm going to skip this because I'll just do I showed you that curve of cold mice before. Here on the right, you see that VLCAD mice treated with a mouse treated with the Moderna mRNA, and that top line is a normal mouse. The bottom line is an untreated mouse, and you can see two different doses of the mRNA. The higher dose is the second line from the top, and that's the higher the dose, the better this stuff works. So we think that this will be an effective bridge to gene therapy, which is actually also something that we're working on. We're working with a company called Kriya Therapeutics, and these are experiments that were done many years ago, before anyone was really interested in trying to make drugs for rare diseases. And I will only point out on the right-hand side here, you can see that same cold treatment. So you have the bottom line heading straight down to the bottom, which is prophetic as to where these mice are going. And if we treat them with the AAV, a therapeutic virus containing the VLCAD gene, we stabilize them, and they can survive the cold challenge. So we're working with the company now to do some additional cell-based experiments. Hopefully, moving this into clinical trials probably take a couple of years. The experiments that I just showed you are being done by Bianca. Please, Bianca, raise your hand back there. She's here, and Eduardo. My Brazilian mafia, they're both from Brazil, and so feel free to storm them afterwards and ask them for all of the information they could possibly give you. They'd love to talk to you. Now we're going to move to something that's already in clinical trials. The Reneo drug called REN-001. We got to get a name, guys. They came to me and they said, well, we want to do these respiratory chain deficiencies. And I said, no, you don't. And they said, yes, we do. I said, no, you don't. And so finally I convinced them that they wanted to do a fatty acid oxidation, long-chain fatty acid oxidation clinical trial. They're still doing that other one, but I was able to talk them into fatty acid oxidation. It's what you do when you've got more time than money. And they've been a wonderful partner. We've been through 2 phases now, and I'm just showing here that when we look at treating cells with VLCAD deficiency with the REN-001 compound, we improve its cellular energetics. We improve its ability to burn oxygen for fuel. Here, every bar that's black is the control, and every bar that's red is the is treated, and high is better on all these graphs. So you can see that for the most part, we're improving energy metabolism in these cell lines, and so we're very excited. Renee is going to be releasing information on the early phase 2 trial here probably in the next couple of weeks, if I understand correctly, and we'll certainly be talking about it in Germany at the Inform meeting. And hopefully we'll be able to move this along. Right now, this trial is in only over 18. I'm lobbying very hard to get that down to 12 or 14 in the next phase, and we'll see what the FDA is, how quickly they let us move down into kids. It works, if anything, better for LCHAD deficiency. These are cell lines, and everything goes up when we treat cell lines from LCHAD deficient patients. So it looks really good there. This drug I did mention and should is something called a Par Delta Agonist. And what the heck does that mean? Well, all of the proteins, all of the enzymes involved in mitochondrial metabolism are made from genes. That's the way the body's designed, right? Your information is all in your DNA. It makes RNA, and then it makes protein. That's something called the central dogma, and that goes back to my early days in biology. It also uses special signals in front of genes called promoters to help the cells coordinate turning sets of genes off and on. So the Par Delta promoter is a promoter that helps control most of the genes involved in mitochondrial energy metabolism and mitochondrial maintenance. It also controls some antioxidant genes that control reactive oxygen inside mitochondria. So on first blush, it sounds like a perfect drug for using in fatty acid oxidation disorders. And our cellular experiments is very, very promising, and we'll see what the first level of clinical trial looks like. The next level, while those data are being analyzed and the results are being released, the trial is in between phases, but hopefully we'll be opening back up for the next phase come the fall. Well, I guess we're almost to the fall. We'll get there soon. I'm doing on time. I'm good. The real question for this drug is going to be how much chronic damage can we reverse? We want to really, if you're already weak and your muscles have already had 18 or 20 or 25 years of stress, how much will this improve it? And do we need to start earlier to really have the optimum effect? And those are things that we'll learn by doing the clinical trials. So, oops, I'm going backwards. There we go. So now, I did the same thing I did 7 years ago. I just spent a lot of time talking about long chain defects. So you MCATers, now's your turn. The first thing I'm gonna point out is that these proteins have very, very specialized shapes. It's called a tetramer. That means it's 4 copies of the protein held together, and the way it's held together is like this. 2 copies of the protein are like this, and the other 2 are like this, and they form this. And I can make that spin again. They form this molecule that you can see rotating there, and right in the middle of that. Those 2 things. I can't point, I don't have a pointer. Right in the middle of that are amino acids, the building blocks of protein that have charges on them. And if you think about the little marble balls, the magnet balls that you played with when you were a kid, if you put them together, and they have to all orient in a certain arrangement because positive attracts negative, and if you try to stick two positive charges together, they push themselves apart. Well, it turns out that the common mutation that causes MCAD deficiency in about 90% of patients with MCAD deficiency change the charges right in the middle of that tetramer. And it's like those marbles. It changes the positive to a negative, or the other way around, I'm sorry, negative to a positive, and it causes that protein to not be stable. And I have some geeky biochemistry that I'm going to skip over. But I will actually back to this. What's necessary for that to happen is proteins are made by adding one amino acid at a time. And so you have what looks like a necklace, beads on a string. And that's not an active protein. It's got to fold up into its final form. And the way it does it for mitochondrial proteins is it's held into this little string until it gets into the mitochondria, and then it starts folding in a special bioreactor. You can think about this now as like a mayonnaise jar with a lid, and you throw a bunch of balls in, some of which are charged, some of which aren't, and you shake it all up and open the lid. And if the protein's got the right shape, it pops out. And if it doesn't, it stays put. You screw the lid back on, you shake it up again, and you hope that it gets to the right shape. Well, long ago in a universe far away, when I was still a fellow in Dr. Kei Tanaka's lab, we were able to show that the protein made by the common mutation gets into mitochondria just fine, but it never folds properly. It never gets out of that mayonnaise jar. That sort of never left me, and a number of years later, we were able to actually make that protein in the laboratory and sort of force it to fold properly. Turns out it works just great. So all we have to do, he said, is make it do that in a cell. Well, how the heck are we going to do that? So here's a picture of that. There's a molecule in there, mostly the green thing, called phenylbutyrate. And phenylbutyrate, it turns out, is a drug that we've been using for decades to treat patients with another metabolic disorder called urea cycle defects. And I was in a clinical trial meeting once where the chief scientific officer of the company was saying, trying to explain the mechanism of action. Well, phenylbutyrate gets two carbons knocked off to make phenylacetate. That's the active molecule. And he said, we think MCAD does that in the mitochondria. And I put my hand up and I say, well, what do you mean you think? He said, well, no one's ever done the experiments. I put my hand back up again and I say, well, I have purified MCAD and phenylbutyryl-CoA in my freezer. Would you like me to mix them together and tell you whether or not it works? And sure enough, it did. Phenylbutyrate or phenylbutyryl-CoA, which is the active form, is metabolized by MCAD. And so at the lab meeting where one of my graduate students was doing those experiments and reported her results, serendipitously at the same time another graduate student was showing the experiments of chemicals that were designed to help MCAD, the mutant MCAD, fold, and she was getting little bits of effect, and it looked like it was reasonable to think about moving forward. And so I looked at the two of them and I said, you guys got to talk, because it turns out that chemicals that bind into the enzyme, what's called the active site of the enzyme, where the reaction occurs, are the best chemicals that help proteins fold. So once again, they changed samples, and as it turns out, indeed, if you treat cells from a patient with the common mutation, the MCAD deficiency, here on the right-hand side, they start out with almost no MCAD activity. If we treat them with phenylbutyrate, we get gangbusters activity, almost normal. So we did a clinical trial. Actually got the company that makes Ravicti, a form of phenylbutyrate, to pay for a phase 1 clinical trial. We treated 4 patients with it. We brought them in the hospital. We fasted them. We looked at the chemicals that accumulate when you have MCAD deficiency, and then we put them on Ravicti, and we measured after 2 weeks. We brought them in and we fasted them and we measured them again. And in 3 of the 4 patients, they dropped, meaning that MCAD was working. And one, he wasn't accumulating anything anyway, so it was just wasn't an informative patient. So about that same time, they shook up their company. Remember what I said. Everybody who I was talking with left, and the people that I was now talking with said, "Nah, we're not interested." So I was unsuccessful in moving this forward until fairly recently. I was talking to the grandparent of a new baby with MCAD deficiency. He said, "Well, how much would you need to do this trial?" And I told him, and he said, "Okay." Turns out he's the CEO of a big venture capital firm in Boston. So I'd rather be lucky than good. And so we're moving forward. We're going to be doing the clinical trial. So if you hear me or you see blasts coming from MitoAction or Fatty Acid Oxidation Support Group, please consider volunteering for the trial. It's going to be, do I have it here? I do. It's going to be, we have to start off with older patients. I think we're going to be able to get down to adolescents. We'll bring you in the hospital. We'll fast you, watching you very carefully, and then we'll start you on phenylbutyrate, and then bring you back in 2 weeks and do the same thing. And hopefully, fairly quickly, we'll be able to tell you that this drug works or not in the older patients. And then we have to move down in age. FDA always wants you to move into older to younger first. And so we'll see what happens. All right. I said hold on to your hats because here's the most surprising thing I'm going to say, at least for me, all day or all meeting, and I think you might be surprised as well. So remember, triheptanone is approved for long-chain fatty acid oxidation disorders. We learned way back when we first figured out what MCAD was that if you gave them medium-chain triglyceride oil, it could be lethal, and patients literally die getting MCT oil inadvertently. That's C8. And so everybody just assumed that C7 would be the same thing, that it would be toxic to MCAD deficiency. Here again, I'd rather be lucky than good. We were doing some experiments where we were measuring activity of various enzymes with various substrates. That goes back to that other set of experiments that I was explaining to you about looking for alternatives for triheptanone. And so we were using an MCAD deficient cell line and VLCAD deficient cell line, and we measured them with C16, the most common natural fat, C8, the one that we thought the VLCAD would be able to use, and it should be reversed in MCAD. They could use C16 but not C8 or C7, and much to our surprise, the MCAD cells metabolize C7 just great. And when we fed mice with MCAD deficiency this drug, if you fast you as an MCAD patient or a mouse with MCAD deficiency, your liver accumulates fat because you can't break it down. Same thing's true for long-chain patients, by the way. And if we give mice with long-chain fatty acid oxidation defects triheptanone, it prevents that from happening. Guess what? It prevented it in MCAD mice too. So here what we see is in the bottom left, a special stain that stains fat red. And if you don't treat mice and you make them cold, they accumulate a lot of fat in their liver. That's red. Now you start treating left to right with triheptanoin, and you get all the way over to the right at the highest dose of triheptanoin, which is still lower than the dose we use in long-chain fatty acid oxidation defects. It doesn't look much different than normal, which is right above it. And it turns out that the next enzyme in the pathway, SCAD, which we've now all ignored for years because we don't think SCAD deficiency is a disease. SCAD can metabolize C7 but not C8. So in MCAD deficient patients, SCAD takes over. And this is another one. We just happen to have all those purified enzymes in the freezer, so we pulled them out and measured everything. It also, I'm going to skip that. It improves the TCA cycle intermediates that we talked about, the succinate and propionate. So it's doing the same thing in MCAD deficiency as it did in long-chain fatty acid oxidation disorders. And if you remember, if you don't, I'm going to remind you that the thing that C7 did best in long-chain deficiencies was stop hypoglycemia. Well, MCAD patients don't get cardiomyopathy. They don't get rhabdomyolysis. They get hypoglycemia, especially in the first 3 or 4 or 5 years of life. So we think we can stop that. We might be able to stop it with phenylbutyrate. Pretty sure we can stop it with Dojolvi. And so I'm just going to move off to the end and say that we have Ultragenics is going to fund a clinical trial using C7 to treat MCAD deficiency. So we're going from no drugs for you to 2. We'll be recruiting for both of those studies later in the year. We can talk to you about, maybe next year actually, it's already halfway through the year. We'll talk to you about the relative merits of both. The advantage of the C7 is it'll work for anybody. The disadvantage is that it might be 2 or 3 doses a day, whereas we think the phenylbutyrate, if you have a common mutation, will only need to be dosed once a day. So there'll be some pluses and minuses to the 2 of them. And if you don't know which one you want to do, then we'll randomize you just the same way we do within clinical trials. So with that, I'm going to stop. Thank you for your attention. Hope you're as excited as I am about all of this progress over since we last all met, really. I'll be around all meeting, be able to talk to you about the various clinical trials that are going to be coming down the road. So please feel free to come and chat with me anytime.
So, Dr. Vockley, we have a few minutes. So, does anybody in the room have a question for Dr. Vockley?
Oh.
I'd like to ask her just a few minutes. Okay, just raise your hand and I'll bring you the mic.
I have a couple questions. First of all, has anyone used mRNA for enzyme replacement therapy in other diseases?
Yes.
Okay.
It's in clinical trials now for 2 inborn errors of metabolism called propionic acidemia and methylmalonic acidemia. They're very early on, so we don't know anything about efficacy. There's also it's also being used in one of the urea cycle defects called OTC deficiency. And thus far, the infusions seem to be going better than the enzyme infusions that we use for all the other diseases that we treat with enzyme replacement therapy. So I think it looks pretty promising.
Okay. And one of the other treatments, when you said the fats don't make it past the liver, has anyone tried using a suppository for delivery?
It still gets into the intestine, and anything that starts in the intestine goes through the liver first.
Anyone else?
But if you want a job, you're hired. We're always looking for people who think outside the box.
Hi, Shirley Rogers, parent of a 6-year-old Leo cat kiddo. Dr. Vockley, you talked about how what you guys found with C7 was that it didn't do as great a job as preventing rhabdo as you guys were hoping. Specifically,
I'm sorry, I'm getting an echo, so I'm gonna put my mask on. I'm gonna come over to where I can.
Okay, is this helpful if I take my mask?
Yeah, I'm sorry, the mask does make it a little.
Yeah, no, for sure. So you talked about with C7, specifically maybe with the Leo cat patients, the rhabdo didn't do as well as you guys had hoped. you talked about with the antioxidant therapy, that did pretty much help the rhabdo. Would that be some?
It helps the cells. We haven't tested it in patients yet, so we don't
okay.
know.
Okay, gotcha. Thank you.
Anyone else?
I'm Michelle. We met you before. My son Jake is 20, has LCHAT. And we did trial the dystrophy before it was FDA approved with y'all. And for Jake, he did get some rhabdo more so than when he took the MCT. So he's back on the MCT, but I was just curious, have you had anyone use the combination of the two now?
Yeah, it is. Originally we kept from using them together for two theoretical reasons. One is that it turns out that MCAT uses C8 better than C7, so we were afraid that we would kind of be interfering with the metabolism of C7 if C8 were around. It turns out that's probably not such a big deal, but the thing that's more difficult is a lot of times we really have to push the dose of C7 up to the max, and if we're using C8 and C7, you have to combine the two in your total medium chain oil, and it keeps you it can keep you from getting to an effective dose of C7. Since C7 makes both C2 and C3, there's really no advantage of using C8 over it or using them in combination. Danielle Carroll, one of our Inform members, has used it in her LCHAT patients together. She just, she said they didn't have access to some of the specialty formulas that they could mix up and get rid of the long chain fats without giving them the included MC2 oil. So she just put C7 on top and it worked okay.
Thank you. So we're going to ask two questions from our virtual group, but I just want to tell everybody there is a basket in the back of the room. If your question doesn't get answered during the session, write your question out, drop it in the box, and we will ask those questions during the roundtable discussions or the panel discussions. So we want to make sure.
Just find me and ask me.
Or find Dr. Vockley. So the two questions, Dr. Vockley. One of the things you talked about is your challenge in trying to find companies to help fund and support and move these trials forward. Are there ways in which patients can help and share their story to help you in encouraging the companies to fund these research initiatives?
The companies that I'm talking to are already interested in rare disease, and so they're just looking for the right niche for them, I actually have lots of your stories already. If you've been to see me, you're in my storybook, and I use it to pitch to pharmaceuticals. If you feel like doing more. Contact me and we'll talk about it. Certainly, companies can be swayed by perceived patient need.
Perfect. And the last question is, if you're a patient, regardless of whether you're participating in a clinical trial or not, are there ways that patients can donate their samples to build up that biobank for research?
Yes, the answer is definitely yes. In particular, fibroblasts, the cells that we use to test all of these drugs, are precious, and we have a bunch, but they don't last forever, and occasionally we lose one and we scramble to try to replace it. The way you can donate those is you can typically just go to your metabolic doc and say, I want to have a skin biopsy. The skin biopsy is very, very easy to do. It's a little cookie cutter looking thing where the cutter part of it is about the opening is about the size of a ballpoint pen. It's about 3 millimeters, 3 or 4 millimeters. We put a little local anesthesia on it, and you don't even need to do anything else. You put the anesthesia cream on it for about an hour. If you look away, I guarantee you by the time you look back, it will be done and you won't even know it. The kids don't like to be, youngest ones don't like to be held down more than the biopsy bothers them. So that then gets grown up. There's a clinical test that they can order to justify it, and then if they do that, they can send me the cell lines with an IRB approved protocol that I have. Or if you happen to be in Pittsburgh for a study and you want to say, hey, how about biopsying me? We can make that happen as well.
Great. Thank you so much, Dr. Vockley. We appreciate it.